Thanks for everybody for hanging on a minute while we dealt with some technical issues. Again, my name is DB Sanders, and I'm one of the co-chairs of the American Thoracic Society PEDS Fellows Track. And I'll actually be giving the first talk today on CF in children. And then our second talk at 5 o'clock will be by Howie Panich. She's the director of the Technology Dependent Center at CHOP, and will be talking to us about their home ventilator program there, as well as some of the broader literature in that area. First, we're going to talk about CF. Again, just some reminders. We'll have the registrations coming up for additional talks next Monday and Wednesday. We'll have the ask for your feedback at the end of the 2 talks so that we can continue to improve these sessions. And your feedback can be on these specific talks or anything related to the program we're doing here. Yeah, I think that's about it. So again, I'm at Riley Hospital for Children in Indianapolis. And my screen will advance. Okay. These are my disclosures, but nothing really relevant to the talk I'll give today. So these are the main objectives for the talk. However, I guess the big caveat is that trying to condense CF into one talk is a little daunting. And so this has a lot to do with my bias and background and where I've trained and the experiences I've had. So hopefully we'll have some complementary materials to what you've learned in your training. There you go. Okay, so we're going to start with CF epidemiology. I'd like to spend a whole hour talking about this, but I will just stick with the basics for now. So again, CF continues to be the most common fatal genetic disorder in Caucasians, though it affects all races. It occurs in about 1 in 3,600 live births in Caucasians, less commonly in African Americans and Asian Americans. There are probably over 30,000 people in the US with CF, as well as over 70,000 worldwide. And in Caucasians, the carrier rate is about 1 in 30. I think an important part of epidemiology is just showing the growth in the number of adults with CF. Over the past 30 years, actually the number of children with CF in the United States has stayed fairly stable at around 10,000. But you can see the growth in the number of adults living with CF from about 5,000 people in 1987 to actually over 15,000 people in 2017. And I think that's an important just reminder to ourselves how much things have improved. And I think something that I try and include in a lot of my talks with parents of newborns is that of all the horror stories they've heard about CF already or Googled already, that there are a lot of positive outcomes. Yet a lot of hard work still to go. I'm just going to go through the basics of the genetics of CF. As you remember, this is caused by problems with the CF transmembrane conductase regulator protein that's found on the long arm of chromosome 7. It controls the movement of salt and water as a chloride transporter. You can see that this spans the cell membrane from the internal part of the cell, transporting chloride out into the extracellular environment. There are over 1,900 mutations described, with obviously F508del being the most common. Here I've modified a little bit a slide from the CF Foundation Patient Registry to show the different classes of mutations where they fall in and how their function or structure is affected. So over on the left of the slide, we have a normal appearing cell with the CFTR in the cell membrane transporting chloride outside of the cell. Class 1 mutation is a production mutation. These are the mutations that end in X as the protein is not produced correctly. Class 2 includes F508del, the most common type of mutation, which is a processing mutation where the F508del is not put into the correct configuration, and so it doesn't make out of the endoplasmic reticulum. Class 3 and Class 4 mutations both result in reduced CFTR function. Class 3, which includes G551D, is a gating mutation where the protein doesn't stay open long enough to transport chloride correctly. In class 4 is a conduction mutation. R117H is the best known example of this, where oftentimes there's abnormalities in the transport channel of the protein that doesn't allow chloride to efficiently traverse the cell membrane. Class 5 and then class 6 are similar. Class 5, the quantity of CFTR that is made is less than it should be. In class 6, there's increased turnover of the cell surface. And as you're well aware, different mutation classes require different CFTR modulators to correct the defect. And this is one slide that looks at the result of the CFTR mutations. On the left part of the slide is an image of normal airway surface epithelia, where the mucus in yellow, which is produced by the goblet mucus secreting cells, are transported up and out of the airway. The mucus sits on the gray represents the cilia in a airway surface liquid layer that stands up and helps transport the mucus. You see that there's an appropriate balance of chloride being transported out of the cell, sodium being reabsorbed, and water balanced correctly. On the also this red bar here to the right of that, the left side of the panel, sorry, indicates that this is well oxygenated airway. On the right part of the panel is the thickened CF mucus that as a result of the inward flow of chloride, sodium, and then water sits on top of cilia that are flattened out because there's no longer an airway surface liquid layer for it to stand up and easily transport the mucus. In addition, on the right side of the right panel is the little bar that shows the gradient from red to blue, indicating that there are areas of the CF lung that is actually anaerobic. One thing missing from this picture that we've learned more about is that the mucus and mucins that are produced in CF are also altered, likely as a result of the CFTR mutation. So that was all of CF epidemiology and pathophysiology, and then we'll move on to other subjects within CF. So we'll talk a lot about newborn screening, and I'll start with the first question here. So question 1 is that newborn screening for a healthy full-term baby girl reveals CFTR mutations F508del and R117H. Sweat chloride levels are 37 and 44 respectively. So which of the following results would increase the suspicion that this child has cystic fibrosis? So answer A would be sweat test, a subsequent sweat test is 55. B, fecal elastase level shows 395 micrograms per gram of stool. C, presence of the 5T form of the poly-T sequence of intron 8. D, presence of the 9T form of the poly-T sequence of intron 8. Or E, sputum culture with Staph aureus. So Liz, are you, there you go, okay. So go ahead and pick which answer increases your suspicion that this child has cystic fibrosis. Oh, okay. So we have a split vote, looks like. The most common answer was that a sweat test of 55 would suggest that this is diagnostic of CF, and the second most common choice was the presence of the 5T form of the poly-T sequence of intron 8. I will stop sharing, and the correct answer is C, presence of the 5T form of the poly-T sequence of intron 8. So technically, that question A was wrong with sweat test of 55 is still below the cutoff of 60. No one really picked on the fecal elastase. The 9T form we'll talk about in a second. And then the presence of Staph aureus is not sensitive or specific for CF. So just as a reminder, the R117H and poly-T sequence affects the splicing of the CFTR and can impact CFTR function. So the poly-T sequence is found on intron 8 of the CFTR gene. 5T alleles are considered mutations. They definitely decrease the efficiency of intron 8 splicing. The 7T and 9T alleles are considered polymorphic variants and have different effects, but typically not reaching the level of CF. I usually go to CFTR2 as a reminder to myself, where they have it broken down nicely. If you have one CF causing mutation, for example, F508del, and then R117H plus 5T, 7T, or 9T, to remind you that the 5T will likely act as a disease-causing mutation. 7T is unlikely to act as a disease-causing mutation, but may result in male infertility. And then the 9T is highly unlikely to act as a disease-causing mutation, and it's unlikely to infect male infertility. The sweat test remains similar to the technology that was developed by Paul de Saint-Agnes over 50, 60 years ago now. It's the only approved method using pilocarpine iontophoresis. The ranges of chloride concentration have shifted a little bit. We now say that for everybody less than 30 is what's considered normal, and over 60 remains suggestive of CF. Depending on which technique is used, there's different minimal acceptable sweat volumes. These are typically reported by your sweat labs, and when you're interpreting sweat tests, you need to ensure that sufficient quantity was obtained. This becomes especially tricky in the newborns who receive most of the sweat tests now. All right, back to another question. So question 2 is again a newborn screening question. So this healthy full-term baby boy has an initial IRT level in the highest 5% of IRT values obtained that day. So for your state, that means that they're going to do a mutation analysis. The mutation analysis reveals one copy of G551D. Sweat tests are subsequently 35 and 38 on the 2 arms at 3 weeks. And so the next step that is performed is a complete gene sequencing, which detects only a missense mutation in CIS. So the question then is, which of the following is the most likely diagnosis? A, cystic fibrosis; B, cystic fibrosis transmembrane conductance regulator related metabolic syndrome, CRMS or CFSPID; C, false positive newborn screening result; D, CFTR related disorder; or E, atypical cystic fibrosis. So we'll go ahead and open up the poll for this one. So which of the following is the most likely diagnosis? We have an infant with G551D, sweat test in the 30s, and a missense mutation in CIS with the G551D mutation. We've had a third of people voting, so we'll try and get up over half. All right. Great. Well, it looks like the most common result was CRMS, which is the correct response. So this is not CF. We have, we're going to that, why it doesn't meet the criteria in just a minute. It's not a false positive newborn screening result. A false positive newborn screening result would be a high IRT, and we find no mutation and have normal sweat tests. So that would be a false positive. CFTR related disorder, it can presents symptomatically, does not come from a newborn screening result. So that's someone presenting with CVAVD or recurrent pancreatitis or something else related to the CFTR, but doesn't come from newborn screening. Then atypical CF is not used anymore. It's not used in our nomenclature. We don't say classic or atypical because we don't always know the correlation between genotype and phenotype well enough to predict the course for patients. So here are the criteria for CRMS or CFSPID, which was coined by in Europe and stands for CF screen positive indeterminate diagnosis, which is really more of a descriptive term than the CRMS, which relates more to a billing issue. I'd encourage you to have this paper on your work laptop so you can refer to it. In this case, this patient had a sweat test less than 60 and had one mutation from the group A or CF causing group, the G551D, and then one mutation from the group D group, which is unknown or uncertain significance and includes many missense mutations. You see here, I did have to cross out. This paper included the sweat test range of 40 to 59 for indeterminate, and now 30 to 59 is considered indeterminate. The other way is to get CRMS, we had to have 2 mutations in group B or D, or you could have 1 mutation in group A and 1 in group B or D, but the sweat test is indeterminate, or intermediate. And then we also have this unresolved or possible CRMS, where you have a sweat test in the intermediate range, but no identified mutations. Ultimately, we want to see what we can do to make the diagnosis. And so the more recent diagnostic guidelines that came out a few years ago includes the recommended pathway that starts with, in most cases, in positive newborn screening, but also in many cases, signs or symptoms, as well as family history. We recommend to sweat all full siblings of newborn infants diagnosed with CF. After the newborn screening or presentation, we begin with sweat chloride testing. We have the different ranges we've discussed. When the sweat chloride is above 60, then we have a CF diagnosis. If we're in the intermediate range, then we're going to proceed to CFTR genetic analysis. If we find 2 CF causing CFTR mutations, we're getting from the diagnosis. On the right-hand side, if you have a sweat test less than 29, less than 30, or no CFTR mutations, then CF is unlikely. It doesn't say CF ruled out. And then for the intermediate range, we proceed to CFTR genetic analysis. The main issue here is that it's recommended that we proceed to CFTR physiologic testing, including nasal potential difference or intestinal current measurement. However, those are not available at many centers, and MPD certainly isn't available for younger children. So oftentimes this last step gets delayed, but if you can identify CFTR dysfunction, then you can also confirm the diagnosis of CF. Another possibility here that could be considered, but I guess isn't officially, would be theratyping performed at some centers, including Cincinnati and Cleveland, that indicate whether mutations are responsive to CFTR modulators or not. But that I think still has a little ways to go. According to the CF registry, people diagnosed in 2016, 84% met the diagnosis for CF. 11% were identified as CRMS or CFSPID, and this is almost certainly an underrepresentation because it's not required that people making this diagnosis are entered into the registry. And then CFTR-related disorder represents less than 5% of the new diagnoses entered into the registry. Again, CFTR-related disorder is also likely underrepresented because its entry into the registry is not required. After going through all this diagnosis and talking about newborn screening, why does it matter? Why are we doing newborn screening? Definitely the strongest evidence is that early diagnosis improves growth. This is data from the original Wisconsin randomized controlled trial of newborn screening, where all infants in Wisconsin were given newborn screening for CF from 1985 to 1994, but the results of the screening were only revealed to half of the parents, and so that half got sweat tests. Those infants were followed from the time they were diagnosed with a sweat test. The control patients either presented symptomatically or at age 3, age 4, they were contacted if they hadn't been presented yet and received sweat tests. And what this shows is the percent of the early diagnosis group and the percent of the control group who had their weight and height below the 10th percentile at each age through age 10. You can say early on, there's a large percent of the control patients who had weight below the 10th percentile and height below the 10th percentile, and that difference was significant until school age. And so the nutrition benefits of newborn screening are well known. The pulmonary benefits are a little bit harder to find, in part because of all the things that go on once the diagnosis is made, including in the Wisconsin study, infants diagnosed earlier were actually exposed to Pseudomonas earlier, which may have impaired their lung function. But there is some evidence. This is data from the CF registry from over 15 years ago that shows the FEV1 at age 6 to 10 and 11 to 20 according to the mode of diagnosis, and that those diagnosed through newborn screening had a significantly higher FEV1 in both those age groups. We can also see with successive birth cohorts, if we follow their FEV1 over time, so each of these lines represents a group of children, group of patients with CF born in different years. The red is 1988 to 1992, and the most recent blue here is really overlapping the brown. You can see that the intercept, where FEV1 starts at age 7, rises a lot more than we see a change in slope of FEV1 over time. So I think this is evidence of a lot of things we're doing early on in life that are contributing, that are ultimately contributing to better lung disease and longer outcomes. And I think newborn screening is a big part of that, even if we haven't been able to show it systematically so far. In addition to improving growth and hopefully improving lung function outcomes, we can avoid complications from late diagnosis. Another way to look at this slide would be ways that CF has presented in the past and can still present today in the absence of newborn screening or in the presence of false negative newborn screening. So we can have electrolyte abnormalities, including hypochloremia and hyponatremia, growth problems, rectal prolapse, vitamin deficiencies, which can present different ways with deficiencies in fat-soluble vitamins. You can have liver complications, including focal biliary cirrhosis and portal hypertension, which can result in hypersplenism, esophageal varices, and even life-threatening bleeding. So I'll focus the next part of the talk on CF lung disease before we come back to some of the other CF complications. So we've talked a little bit about how CF starts with a defective gene, either defective or deficient CFTR protein, affecting chloride and sodium and ultimately water transportation. And then you have this vicious cycle of obstruction, infection, and inflammation. And inflammation appears at the bottom now, but maybe should be moved to the top. As we know that inflammation occurs early on in life and ultimately leads to lung destruction. The right side, the top right panel shows a airway completely obstructed by mucus. The lower right panel shows airway with infiltrate, lots of neutrophils included. I should mention that lungs appear grossly normal at birth and that lung disease begins with the small airways. I also mentioned previously that not included in this figure is that decreased mucociliary clearance with dehydration of mucus and ultramucin should also probably be included in this vicious cycle. Here's you can see the pathology showing explanted lungs in someone who underwent lung transplantation compared to a normal appearing lung. On the right side, you can see giant dilated airways, and there's evidence of enlarged tortuous blood vessels as well that shows sort of the end stage of CF lung disease, the thing we're trying to avoid. There's also an older chest x-ray, which hopefully you don't see appearing too often like this, that shows the increased AP wall diameter. You could see areas of nodular opacities representing that signify mucus obstruction, as well as likely in the upper lobe some bronchiectasis and perhaps in the lower lobe as well. Now I think the bigger issue for us is trying to detect lung disease early and detect progression of lung disease. I've listed here several different modalities we can use. Really, we're clinically limited to spirometry, chest x-rays, and CT scans. But MBW and MRI scans may be useful in the future, though right now they're, I think, still in the research stage. I think it's been well described, the sensitivity of chest CT compared to FEV1, probably even chest radiographs. This paper from 2004 shows this is actually the same patient at age 10 and age 13. You can see the FEV1 has improved from 86% predicted at age 10 to 96% predicted at age 13, whereas it looks like in the right upper lobe, they've had significant progression of disease. Just this is a reminder that CT can detect regional changes, which FEV1 is more of a global measure, and that these two changes don't always correlate in an individual patient. I think you're going to hear more about multiple breath washout next week. Just as a reminder, it's a measure of ventilation inhomogeneity. The lung clearance index is the ventilation required to clear an inert gas. Typically, we're using nitrogen. Other modalities have used SF6. Higher LCI indicates more inefficient gas mixing. LCI and MBW are sensitive to changes in lung disease, especially early lung disease. It tracks with later lung functions, though there are several limitations, especially in the younger children, that require a lot of manpower to get good results. This is what a typical MBW readout looks like. The darker black line going across the screen indicates stable tidal volume breathing. And the key here is to not have a lot of variability in this. And then the lighter gray line that's progressing down the screen shows the washout of an inert gas. And we're looking at the number of turnovers of the lung volume to reduce the concentration to 1/40th of the original concentration. And so the longer it takes, the poorer mixing is, and the worse the lung disease is. And so these two slides illustrate some characteristics of LCI. On the left panel, across the bottom, you have preschool LCI. On the y-axis, you have the same patients who had FEV1 when they were in school. The black triangles are the people with CF, and the circles are controls. So the LCI is abnormal, and this is considered to be abnormal above 7.8. And so you see a lot of black triangles in this area. And in the FEV1 is abnormal below -2, so this lower right rectangle indicates the patients who had abnormal preschool LCI and abnormal FEV1. You can see that none of the circles appear in this area, so it's really good at differentiating between CF, lung disease, and healthy controls. And you can see that most of the infants, the preschool children who had normal LCI, so on the left side of the vertical line at 7.8, also had normal FEV1 a few years later. So this really shows sort of the early predictive ability of LCI in identifying early lung disease. The panel on the right shows that it can be used to detect changes in response to CFTR modulators. So this is a study of preschool children who received placebo or lumacaftor and ivacaftor. You can see within 15 days, just like we see with FEV1, an improvement in LCI that's sustained for the remainder of the study. So hopefully this will become more widespread in the future and help us identify early lung disease in our patients with CF. Right, I'm going to talk a little bit about the inflammation in CF. As I mentioned before, it occurs early in life. It's excessive relative to the burden of bacteria and persists even in the absence of detectable organisms. Certainly contributes to lung damage and is dominated by neutrophils. The oxidants and proteases that are released damage the lung, and the DNA increases secretion viscoelasticity, making it harder to clear. This is almost certainly directly linked to the basic defect in CF. This lung inflammation leads to bronchiectasis, and then the other complications that we hope to avoid: hypoxemia, hemoptysis, pneumothorax, chronic hypoxemia, and pulmonary vasoconstriction, and ultimately pulmonary hypertension, right ventricular hypertrophy, and eventually death. I'll move on to the other part in our vicious circle, which is the lung infections. You're probably mostly familiar with this slide from the CF Foundation registry, which shows the percent of individuals at different ages that have these different bacteria. You can see that staph remains the most common organism, even into the mid-20s or early 30s, before Pseudomonas eventually takes over as the most dominant organism. You can also see, maybe focus on the multi-drug resistant Pseudomonas that's increased, the B. cepacia that has remained pretty low, or that it has not increased, doesn't continue to increase into adulthood. Another paper I didn't include here, but there was a recent paper by Lisa Seaman that looked at changes in microbiology over the last, I think, 10 years in the registry, showing some reduction in different patterns of organisms. Why do we worry about microbiology? Well, we need to know which antibiotics we need to use, and then there's definitely evidence that Pseudomonas and MRSA are associated with poor outcomes. So the graph on the right here shows the change in FEV1 in the years before and after acquisition of mucoid Pseudomonas. Acquisition of Pseudomonas is associated with more inflammation, lower lung function, increased cost of care, and decreased survival. The biofilm that Pseudomonas forms protects it from host defenses as well as antibiotics. Thankfully, we're pretty successful at eradicating Pseudomonas. In the original reports, 72 to 90% of eradication attempts were initially successful, though it does tend to recur in about a third of patients within 1.5 to 2+ years. The recurrence of Pseudomonas is associated with the risk of more IV-treated pulmonary exacerbations, and we really don't have any evidence how to treat recurrences of Pseudomonas, either right away or after a time period. So I'm going to transition now to talk a little bit more about medications, primarily medications for the respiratory disease. One thing I need to show this slide that Jim Schmiel developed, which is looking at different ways that a medication might improve lung disease. Most commonly, you'll see in our medications that are approved for CF, we have the first scenario here where you have an immediate increase in FEV1, and we often don't know if there's a change in the rate of decline, but that's ultimately what we need, because if we have a small bump in FEV1, but the rate of decline doesn't change, it doesn't change survival that much. Ultimately, what we're looking forward is this blue line, the cure, where we just stop lung disease progression altogether. Obviously, we're not there yet, but even more so than a small bump in FEV1, we really would like to see that we can slow the rate of FEV decline, slow the slope of decline. You can see there's a much greater benefit to survival if that's what we can do. Problem is that those studies to do that may take years and are difficult to do. So the original studies that looked at Dornase alpha initially just showed an immediate bump in FEV1 in the first few weeks of treatment compared to placebo. And if you look at this graph where patients were treated for 96 weeks, you can see that a lot of the difference at the end was related to that initial response, and doesn't look like FEV1 decline is affected very much. After about 10 years, Mike Constant was able to go back in the registry and show that it actually does reduce FEV1 decline. But just because it takes so long, you can see why this is not favored by drug companies. In this graph, we look at the FEV1 before, at the time that Dornase was started, or in a comparator group in the dotted line, and then the 1 and 2 years afterwards. And you can see in the group in black, the pediatric patients and the adults, there was an immediate bump in FEV1 in the year that they started Dornase alpha. But if you squint, you can also see that the slope of the decline decreases a little bit as well. Really, the only other drug that it was shown in the original study to reduce decline was ibuprofen. And so if you're not at Cleveland, probably are not using this, but Mike Constant showed that there was almost a 90% reduction in rate of decline over 4 years in children with CF treated with high-dose ibuprofen. Now, the patients that Mike was studying in the mid-90s are a little bit different than the patients we have today. You can see here with the improvement in survival over the past 30+ years. Current predicted survival for a baby born today is about 47 years. And while we're not able to show, oftentimes that our medication leads to direct benefits to survival, I think if you look back over time and actual median survival from the 1940s to 2010, you see a lot of the improvements in survival correlate with the addition of new CF therapies, including airway clearance, antibiotics, and then inhaled treatments. And this stops before we introduce CFTR modulators in 2011. So the most recent chronic medication guidelines are from 2013. So they were published shortly after ivacaftor was approved. So they have not addressed CFTR modulators, but you can presume that they would fit in here as well. These are really addressed at people with CF 6 years old and above. You can see they're strongly recommended for anyone who qualifies for ivacaftor, as well as anyone who has moderate to severe disease, that they start on inhaled tobramycin, Dornase alpha, and or inhaled aztreonam. In patients with milder disease, it's still recommended that they start those 3 medications, as well as for all patients, it's recommended they start hypertonic saline, azithromycin if they have Pseudomonas, as well as ibuprofen. Those I mentioned in the previous slide. Most centers are not doing that. And then the next 3 columns this is a result of lack of evidence for benefit. So they did recommend a case-by-case basis azithromycin for patients without Pseudomonas. I think there is some evidence for benefit of that. They're actually recommending against inhaled steroids, oral steroids, as well as prophylactic anti-staph antibiotics. Okay, so this is question 3. I can't give a talk without talking about exacerbations and early lung disease. So which of the following medications has been shown to reduce pulmonary exacerbations in infants and toddlers with CF? A, hypertonic saline, B, Dornase alpha, C, ivacaftor, D, azithromycin, or E, inhaled tobramycin? All right, well, that's a good spread of answers. So the number one response was hypertonic saline. Actually, the least likely response was azithromycin, and that's actually the ones that's been shown to reduce exacerbations in infants and toddlers with CF. So here's the evidence. So this is data from the Optimize study, which was a study to determine if adding azithromycin to inhaled tobramycin for eradication of Pseudomonas improved eradication attempts. So it was stopped early because azithromycin was showing a reduction in the number of pulmonary exacerbations treated with IV and or oral antibiotics. And this, on the left-hand panel, is the Kaplan-Meier curve for the overall study that showed a hazard ratio of 56% for the patients on azithromycin for a pulmonary exacerbation. On the right, if you look broken down by age, all of the effect was seen in the youngest kids. There was a reduction in the older kids, but you see the 95% intervals cross 1 for all 3 of them. So that's why the answer is azithromycin is shown to reduce exacerbations in infants and toddlers. Ivacaftor, the studies were really too small to see much of an effect there, as well as the studies we have so far for Orkambi, really they're too small, really more of a safety studies for these young kids. All right, so just a little bit about pulmonary exacerbations. There still is not a consensus definition, so we make the diagnosis based on changes in cough, sputum production, weight, physical exam, especially Crackle's energy level, appetite, and lung function. Treatment includes a combination of antibiotics, chest physiotherapy, as well as attention to nutrition. And the frequency of exacerbations is associated with poorer quality of life, lower FEV1, higher healthcare costs, and then in patients with more advanced lung disease, mortality. This slide is a little bit old now, but shows that that the frequency of pulmonary exacerbations treated with IV antibiotics has not changed a lot, at least between 1991 and 2011. About a third of patients are treated annually for at least one IV treated exacerbation. You can see in the first few years of life, the IV antibiotics have been reduced for the more recent cohorts. But even in the adults, there's really not much of a change, even though FEV1 has improved greatly over this time. So it speaks a little bit to our sort of changing definitions of what an exacerbation might be, or at least changing care practices. I think this matters because if we look at outcomes after pulmonary exacerbations are treated, we often see poor improvement in spirometry, prolonged courses of antibiotics due to poor responses in the hospital, accelerated decline in pulmonary function, both before as well as after exacerbations, and then risk of retreatment. And actually, the strongest predictor of IV antibiotics is the frequency of IV antibiotics in the previous year. So this graph is from a paper by Dutch van de Vanter, which somehow I haven't cited here, but shows the Kaplan-Meier, the survival plot for patients without a subsequent IV exacerbations, but based on the number of exacerbations they'd had in the prior year. And you can see that having no prior year IV exacerbations is by far the greatest, has the least likely risk of being treated with IVs again. And if we look at multivariable models where we throw all the risk factors in together, this one comes out by far as the strongest predictor of subsequent IV antibiotics. I also like to mention that treatment decisions are associated with FEV1 outcomes. So Wayne Morgan looked at responses to FEV1 declines of at least 10% predicted. He's done this in the ESCF database, which is from the late 90s and early 2000s, but also more recently in the CF Foundation Patient Registry. And almost over 1/3, so 64% of acute declines in FEV1 are treated, but that means that over 1/3 are not treated. And these are declines of more than 10% a relative change. And so on average, these turn out to be about 20% relative changes. And if you do anything, then the odds of recovery back to baseline or close to baseline are significantly increased. So any oral antibiotic increases the likelihood of recovering back to baseline. But really the winner is hospitalization, even more so than home IV antibiotics. So just as a reminder that we may think it's due to lack of adherence or something else, but treatments do affect how patients recover from these events. All right, and the last thing I'll mention from a lung standpoint is lung transplants. This is really kind of the last stopgap effort when nothing else is working. Although we don't want to wait till the last minute to refer. So it's typically required that there's some stability in the psychosocial situation, there's adherence to therapy, but also just a reminder that to people with CF that we are sort of treating one disease for another for transplantation medicine. When to refer is a combination of FEV1, how fast it's declining, as well as clinical status. Most recently, if we look at the numbers, we're transplanting about 250 people with CF each year. Only less than 10% of those are in pediatrics. For people who have an FEV1 less than 30% predicted, survival is about 6.5 years without a lung transplant. The risk factors for earlier death with an FEV1 less than 30% predicted are the ones we expect. Following lung transplant, the median survival is about 10 years for adults and a little bit over 5 years for pediatrics. This from the CF registry shows that the yellow bars, I think, is what's really increasing over time. And this is indicating, hopefully, the improved survival we've seen over the last 20 years for lung transplant. Similarly, if we look at the death recorded in the registry, that number is going down as well. Although oftentimes once patients have lung transplant, they are lost to follow-up in the registry as they switch to a transplant clinic. Though we have been getting better at keeping those patients in the registry. All right, so I need to talk about CFTR modulators, and then I'll touch on some of the other aspects of CF disease. So the ones you know about are the potentiators and correctors, the ones that increase the open probability of the chloride channel, enabling it to conduct chloride, and the correctors that help misshape CFTR fold in the correct orientation so they can get to the cell surface. There are also companies working on amplifiers that would increase the amount of CFTR protein that's produced, and stabilizers, which decreases the turnover of the protein at the cell surface. I think probably all familiar with the tremendous results from ivacaftor, and so I'm not going to go through this figure, but the original paper from 2011 really was greeted with great excitement, deservedly so. I mentioned before, wanting to show slowing rate of decline of FEV1, and those have been shown in longer studies using registry data that shows that patients with G551D and ivacaftor have a slower rate of decline compared to registry controls, less than 1% predicted per year. And similarly for lumacaftor, ivacaftor, we see that the rate of decline is reduced to less than 1.5% predicted per year compared to the registry controls, which was still over 2% predicted per year. All right, I think this is the last question. So the question is, what is the mechanism of action of the triple combination CFTR modulator Trikafta? So A, potentiator corrector, B, potentiator corrector amplifier, C, potentiator corrector, D, potentiator corrector stabilizer, or E, potentiator corrector read-through suppressor, which I didn't really mention, but which of those 5 is the correct combination in Trikafta? All right, great. So actually last year, I asked the same question last year when I gave the talk, and most people got it wrong, but this year most people got it right. So the correct answer is C, the potentiator corrector. So I think having the medication on the market now actually makes it easier for people to know. So I'm not going to spend a lot of time talking about, but these were the phase 3 results that were published last year in the Lancet and in the Journal of Medicine. In people with 2 copies of F508del, FEV1 was improved 10% versus tezacaftor and ivacaftor alone. And then in 400 patients with one F508del and 1 minimal function mutation, FEV1 was improved 14% over placebo. There's almost a 2/3 reductions in pulmonary exacerbations. This slide just to mention that while we've so far worked on ways to improve performance of the protein, there are other areas in the pathway that we can look to address with our treatments. And that starts right at the gene level through gene editing, gene delivery, stem cell biology. CRISPR is not mentioned here, but most of our therapies have addressed the symptoms, and we're starting to get back up the pipeline to getting more at the root cause of the CF. All right, and there's just a few minutes, so I'll go through some of the other disease features. I think these slides will be available later, so if this is something you want to review. It's obviously not all about the lungs. CFTR mutations can affect multiple systems. They're also modified by modifier genes, which we often don't know about. Environmental exposures, especially smoke, cigarette smoke exposures. There are therapeutic complications of therapies and iatrogenic effects such as hearing loss with some of our aminoglycosides. Meconium ileus and DIOS, the meconium ileus is one of the earliest complications we can see. It's still about 15% of infants with CF. Results mostly from inspissated fecal material mucus in the small bowel. DIOS still occurs. We've had a run lately of patients here at Riley. The annual prevalence is about 2 to 3% of patients and results from thick intestinal secretions, malabsorption, as well as decreased gut motility, which is fairly common in people with CF. Pancreatic insufficiency, obviously, it still affects nearly 90% of patients with CF, and usually they convert within the first year of life. You're familiar with most of the signs and symptoms, as well as the consequences of pancreatic insufficiency, including malnutrition and fat-soluble vitamin deficiencies. A couple of ways to diagnose pancreatic insufficiency, and I leave it up to you, to your preferred test. You can do a 72-hour stool collection to determine fat absorption, or you can just send a laboratory test with a single stool sample looking for fecal elastase. Levels less than 100 micrograms per gram of stool have an excellent predictive value for pancreatic insufficiency, and enzyme replacement has been recommended for levels below 200. If we look at CF guidelines for replacement therapy, the recommendation is 500 to 2,500 lipase units per kilo per meal, titrated based on symptoms and growth. If we look at the infants enrolled in the recent observational bonus study, the average was about 1,800 lipase units per kilo per meal. These are in children under the age of 1. The thing we worry about for overdose is fibrosing colonopathy. So it's recommended that we limit to less than 2,500 lipase units per kilo per meal, or 10,000 units per kilo per day. For our infants and young children who are eating more than 3 or 4 times a day, we can easily pass the 10,000 mark, even if we're within the goal. And the infants enrolled in the bonus study had up to 1,200 lipase units per kilo per day. And we're doing a longitudinal study nationwide to look at the incidence of fibrosing colonopathy with FDA-approved enzymes. In addition to the enzymes, we're also going to replace fat-soluble vitamins and a high-calorie diet. It may, even for our healthy infants with CF, over 120% of the recommended intake may be necessary to maintain adequate growth. Nose and sinus disease shouldn't be ignored. Nasal polyposis and pansinusitis is associated with poor quality of life. There's a lot of interest in adult CF to try and improve outcomes for sinus disease. If you discover polyps in a non-CF patient, this may be an indication for a sweat test. CF-related diabetes is a result of insulin insufficiency and resistance. Insulin resistance that leads to carbohydrate intolerance. This is different from type 1 or type 2 diabetes. DKA is very rare, and we're not restricting diets because it's the desire to maintain high fat, high calorie diets are still there. I think this is a result from the pancreas being replaced by fat via autodigestion of the pancreas by pancreatic enzymes that can't escape the pancreatic ducts. The islet cells eventually disappear, and so yearly oral glucose tolerance test is recommended for by at least age 10 or even earlier if you're concerned about malnutrition, other evidence of diabetes. And this graph from the CF Foundation shows the prevalence of impaired glucose tolerance in red and CF-related diabetes in blue. And you can see the incidence really picks up after age 10 and continues to increase into adulthood. CF osteoporosis is also common, especially now that we have longer survival. This result of vitamin D deficiency in some of our medications, including when we're using PPIs quite a bit to help with enzyme function. Probably should spend a lot more time talking about depression and anxiety and CF, especially now that we know how tightly linked outcomes are to these mental illnesses. You see the prevalence for depression and anxiety in both increases greatly through the teenage years and into adulthood. And then, I was at a meeting once where somebody mentioned that they were talking to their 18-year-old with CF, and they had completely forgotten about the effect on reproduction because it was something that was mentioned at the time of newborn screening, but wasn't really mentioned again until the young adult. It came up again. So I think it's a good reminder that our patients need to know that virtually all males with CF are infertile due to congenital bilateral absence of vas deferens, although it's not universal, and men may father children with CF. 1 to 2% of infertile men have CFTR dysfunction. And most women with CF are fertile, but there is definitely a subfertility, maybe related to thickened cervical mucus, and it seems like there are reports on Trikafta of increasing frequency of pregnancies in women with CF. All right, so sorry I had to race through the non-lung disease complications of CF, but the take-home points I want to leave you with were that the importance of newborn screening and how it's changed our care of CF, which are really becoming more preventative than responsive. Frequent monitoring and early detection of disease progression is key, though even in the area of CFTR modulators, inflammation and pulmonary exacerbations are likely to occur. That being said, CFTR modulators and hopefully other next-gen therapies will offer significant benefits. So I'm going to stop there. If there are any questions, I think you can put them in the chat. Request to be unmuted. And then we will get over to the next talk in a few minutes.
DB, that was a great talk. Often one of the common things that we see with newborn screening and patients is F508del, R017H, 7T/9T. So how do you interpret that report? Like the 7T and the 9T, which mutations do those go to? And if you're unsure, how would you figure it out?
Yeah, I have not seen too many of those reports. So, yeah, I mean, I think that's sort of the issue to, if we're not following the classic CF diagnosis is to pay attention to those mutations. I think we discussed earlier this year that there is an increased frequency of complications in people with, even CF carriers, probably much higher than we think. So I don't think there are any official guidelines on those. It may be that we still need some help in figuring that out. I'm not sure maybe I'll have you tell me what you do with those patients.
Yeah, well, so I think the F508del only occurs on a 9T background, so the 7T goes with R017H. But I think the point is oftentimes regardless of what the mutation is, maybe it's G551D and it's and it's a 7T and a 5T, and I really want to know what T's and I have no idea what background G551D appears in.
Oh, that's what you're asking, yeah.
Yeah, I draw them.
Finding if it's cis or trans, yeah.
Yeah, I draw the mother's blood and see what mutation
Yeah.
she has, and then assume the baby's going to have the same one. So you'll know if it's in cis or trans with the R17H. I do not draw the father's blood. Geneticists will often tell you to draw both parents' blood. I have had instances in my career where the person in front of me was not the biologic father.
Right. Yep.
I usually just draw mom's blood if I'm trying to figure that out.
Yeah. So it looks like one question is azithromycin reducing exacerbations, is that just in the setting of Pseudomonas eradication? Well, I think that's the only place that it's been shown is in the optimized study, which was a study of Pseudomonas eradication, but was stopped early because of the reduction in pulmonary exacerbations. So I think it's a fair question. It hasn't really been studied outside of that setting, at least in the young population.